This presentation is a step-by-step guide to performing the Medtronic CoreValve percutaneous aortic valve replacement procedure using the CoreValve system. Note, this animation is intended as a training supplement to the CoreValve training program and is not meant to replace the training program or the instruction of a CoreValve therapy development specialist and proctor. Make sure that the patient is comfortable and in a supine position on the cath lab table. Establish a central venous line. Insert a 4 or 5 French temporary balloon tip pacemaker catheter via the right internal jugular vein or other appropriate access vessel and position it in the apex of the right ventricle. Prep both the patient's groin areas. Insert a 5 or 6 French introducer sheath into the contralateral femoral artery. Insert a graduated pigtail catheter through the introducer sheath and advance over a guide wire to the primary femoral artery. Using contrast injections, isolate the access site and puncture artery using a 18-gauge thin-wall needle. Note, it is important to puncture using a high degree of angulation to minimize skin-to-artery distance. Insert standard 035 J-tip guide wire through needle and advance into the common femoral artery. Insert 9 French introducer over guide wire to further dilate vessel. If indicated, exchange 9 French introducer for pre-closure device. Remove guide wire as pre-closure device is advanced through artery. Deploy sutures and reintroduce guide wire as device is retracted. Secure sutures to sterile drape. Reinsert the 9 French introducer over the guide wire into the femoral artery. Advance angiographic catheter over guide wire and place in descending aorta. Exchange standard guide wire for 035 super stiff guide wire. Remove angiographic catheter. Exchange 9 French introducer for an 18 French introducer. Remove super stiff guide wire. Administer anticoagulant according to hospital protocol. If heparin is administered, check activated clotting time and monitor every 30 minutes after initial bolus of heparin, and maintain ACT level greater than or equal to 250 seconds. Note, heparin may be administered at any time before, but avoid delaying beyond this point. Now, advance the 5 French graduated pigtail catheter to the ascending aorta and place the tip in the non-coronary cusp of the native aortic valve. The pigtail catheter will serve as a visual reference marker during deployment. Identify ideal annular viewing plane using small contrast injections at various angiographic angles. When ideal viewing plane is identified, perform aortography using a larger bolus of contrast. Please note, a dedicated individual should be assigned to prepare and operate the contrast injector. Insert 5 or 6 French angiographic catheter over guide wire and advance to the ascending aorta. Switch the standard guide wire for a 035 straight tip guide wire. Advance the guide wire across the aortic valve into the left ventricle. After crossing the native aortic valve with the guide wire, advance the angiographic catheter into the left ventricle. Switch the straight tip wire for an exchange length 035 J-tip guide wire. Exchange angiographic catheter for a 6 French pigtail catheter. Remove the guide wire and connect the catheter to the transducer. Using both catheters, record the aortic pressure gradient. Using a RAO projection, advance the pigtail-shaped 035 super stiff guide wire through the pigtail catheter into the apex of the left ventricle. Remove pigtail catheter while maintaining guide wire position in the left ventricle. Insert dilation balloon through the 18 French introducer sheath and advance to the ascending aorta. Now, let us perform a rapid pacing test. Set pacing generator to an output rate of 160 to 200 beats per minute. Note, output range will vary among patients. Begin pacing. As shown here, a successful test is defined as 1-to-1 pacing capture with an immediate drop in pressure and elimination of the systolic-diastolic waveform. Upon completion of successful rapid pacing test, we can continue to the pre-implant dilation. Reposition the camera to the ideal viewing plane as previously described and advance and position the balloon across the native valve while maintaining strict fluoroscopic surveillance of the distal tip of the guide wire in left ventricle. Give the command to start rapid pacing. Following a significant drop in systemic blood pressure and pulse pressure, inflate balloon. Once the balloon is fully inflated, deflate the balloon and stop rapid pacing. Remove balloon while maintaining guide wire position across the native aortic valve. Load the Medtronic CoreValve system onto the 035 super stiff guide wire and advance to target position. Use the micro knob to begin the initial deployment of the bioprosthesis. During the deployment process, various angiograms should be taken to ensure proper valve placement. Withdraw delivery catheter to the descending aorta while maintaining guide wire position. Close the delivery catheter capsule and remove the delivery catheter over the guide wire. Advance a 6 French pigtail catheter over the guide wire into the left ventricle. Remove the guide wire and connect the pigtail catheter to the transducer. Using both pigtail catheters, record aortic pressure gradient. Remove 6 French pigtail over standard guide wire. Perform post-implant aortogram with the 5 French reference pigtail. Remove the 18 French introducer sheath and complete the puncture site closure. Withdraw 5 French reference pigtail to the aortic bifurcation. Perform contrast angiography of the primary iliac and femoral vessels to document proper closure of the primary access site, as well as the absence of any other vascular complications. Remove the 5 French reference pigtail over a standard guide wire and close access site per hospital protocol. Please note, this animation is not intended to replace physician's medical judgment with regards to patient care, and it is expected that one or more steps of procedure may be modified specific to the individual patient's needs.